All right, can you hear me, Larry?
Can hear you very well.
I'm an electrical engineer and a software engineer. You'd think I'd be able to figure this thing out, right?
No, you know too much.
Yeah, maybe that's what it is. All right. Good morning, everyone. My name is Mark Lefebvre, and I'm really grateful to be here this morning and have an opportunity to share with you and with Larry and Carolyn. We're all from Pine Tree Institute. I'm the director of community engagement. I'll let Larry and Carolyn, once we get into this thing for their sections, introduce themselves. But what we have here is a presentation that basically I'm jumping through prematurely. A presentation that covers a number of different topics, but specifically what we're going to share with you today is the very brief recap of ACES and adverse childhood experiences and the downstream impact of ACES on public health, individual health, public safety, and so forth. And then we're going to pivot quickly into what we call pieces, positive childhood experiences, and social determinants that allow communities and individuals and families to build resilience against this trauma in an effort to break the transgenerational cycle of adverse childhood experiences. We'll also be talking a little bit about developmental assets and relationships that serve to arm our communities with the ability to make a difference in a child's life. And then we have a real live example that I'll share with regards to the Portsmouth coordinated response to substance use disorder. Before we jump in, I'd like to acknowledge the generosity of a number of different foundations and organizations that have funded a lot of the work that we're doing, including the ACES Master Training Program. Some of you have been the beneficiary and recipients of some of this training, the Ambassador Program, and what we're doing with regards to substance use disorder, coalition building in Portsmouth, Seacoast, and greater Kennebunk area, where we have a number of different projects underway. And then we're going to start here with kind of an exercise. I'm going to have to shrink my screen here so that you get the barcode. I just realized it's off screen. So let's do this. And what we're going to ask you to do, just to get used to the technology that we're going to be using here, and hopefully we're not treading into the deep end too far with the technology, but if you use your phone to take a picture of that QR code, it's going to take you to a Slido page where we'd like to do an informal, do you prefer winter? Do you prefer summer? Or do you hate winter or do you love winter? And we'll show the results of that, I believe, Carolyn, by sharing my screen. Everybody have that picture? And Carolyn, if you can unmute yourself, where will the results show up? Do I have to share the Slido page?
Yes, you have to share your Slido page, or I can, if you let me share, I can share it. I have it up.
You should have the ability to do that. I already gave you permission. So I got to stop screen sharing and turn it over to you. Look at that. Love winter, hate winter.
Let me see, should be going.
I'm glad that we're testing this out in the forefront.
Yes. It was showing over here. Hold on. Here it is. Let me present it.
Look at you.
Huh.
It's up in the right-hand corner, I think.
So it says that 26 people have responded. I'm just going to take it out of present mode and you'll see it.
Oh, okay. There you go.
Oh, results are hidden, show results. That's why. Here we go.
Good. That's exactly what we wanted to accomplish with this little fun, because later on we're going to use this tool. All right. Thank you, Carolyn.
Oh, it must be the middle of January. Nobody likes winter.
Except for Mark.
Yeah, exactly, right? So Carolyn, if you could stop sharing, and then I'll go back to the deck.
Perfect.
And Larry, I'm going to turn it over to you before I hurt myself.
All right. So do you want, you're going to bring the deck back up?
It is, should be.
Not yet.
All right. Oh, hit share. All right, there we go. And
There
then
we go.
screen.
All right.
There you go, Larry.
So, as Mark said, we've done so much technology in the last 2 years. Some of you, I've actually met many of you in other venues. So it's great to see you. I did a similar presentation for the Addiction Summit just a little over 2 years ago. So it would have been, let's see, fall of 2019. And of course, the world was about to change and we had no idea. But many of you, since that time, have been engaged in various ways in some of this work. And some of it has really developed since, I was thinking back, and actually Mark and Carol and I were sort of reflecting on the progress of the past couple of years. And in some ways it's been, things we could never have imagined. And yet in other ways, it has really developed. So the ACES training program, for example, our ACES master trainers, some of whom were on this call, so it's great to see you, have presented to, we think, close to 1,500 people, and all on Zoom in the last year and couple of months, in ways that we never imagined, and groups that we never imagined would be able to get together like that. So it's been quite an adventure. And what we really want to do today, I'm just going to do a quick overview of ACES. I think many of the people on the call are familiar with this work. So we're not going to dwell on it a lot, but it's really just to set the stage and to remind us that the ground of everything we want to do needs to be informed by an understanding of the impact of early childhood experience really on all of life experience. So I think many of you know the basic story of ACES. Rob Anda and Rob Folletti did the basic research late 1990s and looked at the correlation of 10 different types of childhood experiences of abuse and neglect and household dysfunction. And what they found on the next slide, as many of us know, is that they found that these experiences were much more common than they actually expected. We had the great privilege to work with Rob Anda a year and a half ago, fall of 2020, worked with Rob Anda and Laura Porter. And Rob is very poignant. He said when he pulled us up, he was the first one to see these results, and that it actually brought him to tears because he had no idea that there was this level of adverse experience in our population. And as many of you remember, this population was mostly middle income, mostly white, mostly college educated. This is not at all a troubled population in the sense that term is often used. And as they looked at it, the next slide, they also found that you could add up the number of ACEs, and that gives you a proxy for a dose of stress. There's no direct correlation between 4 or more ACEs and certain kinds of illnesses. But what they found is that the more ACEs, just doing a raw count, the more likely individuals were to have health, either mental health, behavioral health, or physical health issues as an adult. And in fact, a couple of the issues, the next slide, that really affect the audience, our group today, what we're thinking about is 2 of the adult issues that are most strongly affected by adverse experiences are substance use disorder and suicide. And you can see on the chart at the left, as the number of ACEs goes up, the percentage of people who are involved in IV drug use goes up. The suicide ratio is actually quite astonishing. People with no ACEs, about 1 in 100 attempt suicide at some point in their life. If you move that up to 7 ACEs or more, it's about 20 out of 100. About a fifth of that population at some point will attempt suicide. So there's a strong correlation between these adverse experiences and these two. As we look at the next slide, it's really trying to understand, so why would this be? We frequently focus at the top of this pyramid. We look at disease, we look at health risk behaviors, maybe look at the social and cognitive functioning. But what is growing as an understanding is that the adverse childhood experiences, and even beyond that, intergenerational experiences of trauma, are big contributors to adult disease and difficulties. When we look at the next slide, and this is one of the pictures that for many of us sort of brings it all home. So this is what is called the population attributable risk. And what that means is it's the percentage of a particular issue that can be attributed to high levels of ACEs scores. So if you look around the circle, many kinds of issues, but look at sort of lower left, look at IV drug use. 78% of IV drug use is accounted for by differences in ACEs scores, meaning that people with high ACE scores are much more likely to be involved in IV drug use, sort of follow it down to the right, alcoholism, suicide attempts, mental illness. And then if you look up at the top, even things like interrupted activities or job injury or illness or being out of work. What's significant about this picture for us, Laura Porter, who we worked with, affectionately calls it the oil slick slide. So it's like they've got this oil slick. So imagine if you actually turned this flat, and that was an actual oil slick. If you push really hard on one area, let's say we push the oil on IV drug use, and you've got a flat surface, what happens to the oil? It just goes somewhere else. So the idea of working with ACEs is you drill a hole in the middle and drain the oil. If we reduce the adversity, then not only are we addressing IV drug use, we're addressing all of these other issues around the circle. And that's the image that many of us remember. In fact, we often talk about, what we need to do is drain the oil. And people haven't seen this picture say, what are you talking about? But that idea of draining the oil is the whole, it's the key insight that has come out of the ACEs and the trauma-informed care work. And of course, this has been developing over the last 20 years. So there's quite a bit of understanding. If we look at the next slide, actually back up to Mark, back up one more thing on the oil slick slide. At this point, I always like to remind people what we mean by population attributable risk. And many of the people on this call, you've seen ACEs before, you've probably already done your own personal count. The first time I saw this, I was running through my own count, and I personally have a very high ACEs score. And I sort of ticking these off. And I said to Laura Porter, I said, do I need to be worried? I've got a really high ACE score. And what she pointed out, and this is really important for all of us on this call, but also all of the people we work with, ACEs are predictable on a population level, but they are not predictable on an individual level. It's just like smoking. If you smoke 4 packs of cigarettes a day, it's highly likely that you will have lung cancer, but it doesn't mean that you will have lung cancer. And there are people that smoke a lot of cigarettes who don't get lung cancer, and some people who smoke no cigarettes that get lung cancer. So it's really important to remember that ACEs are an indicator, very predictable on a population level, not predictable on an individual level. Which then brings us to the next big question. So what do we do about this? And this is really where we at Pine Tree have been focusing our work over the last couple of years, is how do we understand what's some of the impact that can help to buffer the impact of adverse experiences, because we know that some individuals have really high number of ACE scores, but they have some buffering experiences that then help them to thrive. So we've really tried to understand this. And about a year ago, on the next slide, we had some wonderful time with Christina Bethel. And I think some of you may have been with us. That was a Zoom call. Christina has done some of the seminal research similar to the ACES work, but looking at the other side. Are there positive experiences that actually help to buffer the impact of ACEs? And if you want to read about her work, you can Google NPR, positive childhood experiences, and work pops right up. But she led a wonderful bit of research that starts to demonstrate that positive experiences can have a buffering effect. And on the next slide, she, and this was a great opportunity, she was able to work with the state of Wisconsin that had introduced some positive statements into their statewide survey. And they were able to correlate people's responses to some of these positive experiences to some of their reported health challenges as an adult. And they looked to see if there was any differences, really very, very similar to the ACES study, just looking at positive experiences. And they were able to look at these things. Were you able to talk to your family about your feelings? Did you feel your family stood up for you? Did you feel safe and protected? Were there at least 2 non-parent adults who took genuine interest? Did you feel supported by your friends? Feel a sense of belonging in high school? I love the high school one because I always thought maybe it was over by high school, but high school apparently has a big impact, and enjoyed participating in community traditions. So the chart on the left here, so green is good. The people that's had higher levels of these positive experiences reported lower levels of adult mental health and depression. So the orange were low levels of positive experience, the green were higher levels. And for each one of those, they found that if people had experienced that, they were less likely to experience depression and poor mental health. And this is just one chart. They looked at a number of different issues, but found this impact across the board. And they did then the second step. So is there a cumulative effect? Just like in ACEs, there's a cumulative effect. And in fact, that found in fact that there was. The more positive experiences, the greater the impact on a reduction in challenges with depression and poor mental health. So this gives us the capacity to say, okay, so are there ways, maybe we can't directly impact some of the early experiences, but in some ways, maybe we can by working with parents, by working with prevention and early childhood. And we're starting to think about that quite a bit. Carolyn will talk about that in a few minutes. But even if we can't impact that, maybe there are positive experiences that we can provide. And if you look at the list of experiences that Dr. Bethel looked at, the first 3 are in the family. Maybe as community members, we can't directly impact that. But the bottom 4 are all community factors that we can directly impact. And in fact, that's what comes out of Laura Porter's work. If we look at the next slide, Laura Porter, who did over about a 10-year period, some amazing work in Washington State, where they looked at community education, just like we're doing now. And when communities began to shift to more of a trauma-informed approach, what they found was that certain social issues actually did start to decline. So in the green box here, Laura Porter and her group identified 4 community factors, and this is very similar to the positive experience work that Christina Bethel did, different type of research, but converging. Some of the community factors that made a difference. So emotional support. Do you feel that you have a source of emotional support? Multiple sources. Are there two or more people? Just like in Christina Bethel's work, research. Reciprocity. This is doing things for other people. I'll weed your garden if you watch my kids. I'll go to the store if you can take care of my car. Whatever it might be, being able to exchange. And then the fourth one that I love, which Laura Porter calls social bridging, which is a capacity to reach outside one's normal social circle. So if we think of all of the things that we can do in communities, anything we can do that helps to build bridges beyond our own insular community. A little hard right now when we're all on Zoom, but people are finding ways. That capacity to reach outside my own community group for resources and for help is a big factor in being able to develop the kinds of positive community experiences that then are helpful to me. And the charts on the left here, they actually tracked, they were able to do some very careful data tracking. And the communities that adopted trauma-informed approaches, those are the green lines. This happens to be a teenage example, but found that high school dropout rates went down at a greater rate. Freshman to senior dropout went down. Alcohol juvenile arrests went down. Drug juvenile arrests went down. The red were the communities that didn't change what they were doing. The green were communities that started to change their approach, were able to demonstrate that they made a difference. Now, this is over a 10-year period. So you have to take that long view. But they show that it is possible to actually make substantial change over time. In fact, they documented a savings in Washington State of close to $10 billion in saved services from the communities that adopted trauma-informed approaches. So it has a huge impact. So last piece, many of you have seen this, so I'll just touch on it quickly. One of the drivers of the power of this is that there is an intergenerational impact. And what they found in Washington State is that you could predict the ACE scores of children from the ACE scores of their parents, right? Which makes sense. What they found is that when they were working with parents to improve their health outcome, that the children's health outcome improved as well. And you know, all of these things that we're concerned about on the left, obesity, mental health, happiness, financial concerns, all of those had an impact on children's well-being. So to bring this, sort of sum this all up, well, we're going to do one quick little activity back on Slido. And admittedly, I know I ran through this really fast, but I also know that many of you have a pretty good understanding and that many of you have been working to adopt trauma responsive approaches. So we'd love to take a moment on Slido, and you go back to Slido, you can just type in your response. We'd love to see some responses. How has trauma responsive thinking, how has it impacted your work, or how do you imagine that it might impact your work as you're working with others? And you can just type in your response. The answers will start to roll down the screen as we enter them in. So what has been the impact of trauma responsive thinking, or what do you imagine it could be in the work you do? We'll give you a minute, because this is a typing activity. There we go. Oh, hope. You know, I actually had the exactly same experience. Approach people with kindness. You never know what their history is. Surprising people have really high ACE scores. Yeah. How am I going to help social bridging? Big one. Yeah, and a lot of us have the capacity to help with that. Good for all. That's right. It's not just those trauma people. It's increased genuine relationship building. Oh, great. ACERT coordinator. We love ACERTs. We're going to come back to that later on. Like to be able to connect people, more positive experiences. Yeah. Social bridging. These scroll really fast. We'll scroll back down. Empathy is a big one. Laura Porter talks about engaging with empathy and finding a way to create right fit, rapport, and build empathy, support, guidance, which is huge. Many people just need to know that we understand. Yeah, and you can also enter in chat if you're not in Slido. Chat's another great way to enter these. So
I can monitor that, Larry.
Opportunities. Yeah.
Yeah, from the chat, more opportunity to provide restorative opportunities for youth early.
Yeah. So Carolyn, can you scroll down on the Slido just a little? Oh, actually, well, I have to answer to get in there. Connective, where kids are, yeah, ACERTs, we're going to come back to that. Much more intentional at social, physical structure and materials to provide some stability, very important, right, to maintaining that environment. Connect more effectively, genuine relationship, that is exactly where we're going next about relationships. Where are we? Yeah, I love that. I mentioned the good for all, but sometimes we laugh. Sometimes people will talk about, well, this is what we do for those trauma kids, and we have emphasized it's not just for, quote, the trauma kids. One of the reasons is we don't actually know who the trauma kids are. Some trauma kids express it. I mean, you have a sense. Others, we don't really know what people's stories are. So it's building the positive relationships for everybody that helps bring that along. So these are great. These are wonderful. These are exactly the kinds of things that we have been hearing from people. And we know that many of you are working on implementing these. So what I want to do, quick overview. I've done 2 hours on the materials that I've just done. Many of you have done 2 hours on the materials that we've just done. So I know, but we wanted to just make sure that we were grounding in that experience. What I'm going to do is turn it over to Carolyn Eastman, who is going to take that next step on, so how do we actually build those positive relationships? So Carolyn, let me pass it to you.
Thanks, Larry. So Mark, if we're going to talk about the next piece on creating intentional positive relationships, and this builds off of Dr. Christina Bethel's work. If we could go to the next slide, Mark. So the former CEO of the Search Institute, and I know for a fact that many of you are familiar with Search Institute, we love their research and their developmental frameworks. Relationships are the single most important factor in youth development. After decades of forming hypotheses, conducting surveys, crafting and rewriting definitions, analyzing data, and writing journal articles, Search Institute researchers and practitioners have arrived at a surprisingly simple conclusion. And I think we all have realized this even more so during this pandemic, that nothing, absolutely nothing, has more impact in the life of a child than positive relationships. Next slide, Mark, please. So who else believes in relationships, that they're the single most important factor? Well, here are a few organizations, and we know that there are many, many others. And I know there are people representing organizations in this meeting right now that put relationships at the core of everything they do. Search Institute, the Christensen Institute, Brene Brown, love her. David Brooks, The Second Mountain, if you've ever read his books, he talks about bringing back this idea of having a relational society, that we've gotten into these silos of being independent and picking yourself up by your bootstraps. But he really believes that we need to get back to being relational. Unlocking innovations, expanding social capital and networks for youth. And Turnaround for Children, Dr. Pamela Cantor, if you're familiar with her work, fabulous work around youth development and relationship building. And then last but not least is Gallup, believe it or not. Gallup does a student poll that really measures the relationship between hope, belonging, and engagement for youth. In the state of New Hampshire, we've actually included a section on that related to work-based learning and the relationship of kids having experiences related to work early on in their interests that then increase engagement, hope, and belonging for kids. So Mark, next slide, please. So the Search Institute developed a framework called developmental assets. There are 40 different assets that are grouped into 8 areas of human development. Percentages of young people who experienced each asset were actually gathered in 2012 through 2015 through Search Institute has a survey called the Profiles of Student Life, Attitudes and Behaviors Survey. There were over 121,000 students and youth that were surveyed to develop what they are calling internal and external assets. So they have identified these forward-facing and internal assets as the following building blocks for healthy development, known as developmental assets. These help young people grow up healthy, caring, and responsible. And you can see those external assets are support, empowerment, having boundaries, learning about boundaries and expectations, constructive use of time, and those internal assets of social emotional learning, a commitment to learning, having positive values, social competencies, and a positive identity. Mark, the next slide, please. Here's a slide that goes a little bit deeper into these external assets. These focus on relationships and opportunities they need in their families, schools, and communities. This is about us and our families and how we can help youth. The next slide, Mark. And these internal assets really focus on social emotional strengths, values, commitments that are nurtured within young people. So a commitment to learning, social competencies, that positive identity. You know, out in Silicon Valley, they had actually, at a YMCA, Katie and Kim, they had actually developed another asset that was about cultural identity, that how I view my culture and my cultural identity is really important as an internal asset. So that's one that that group out there had added to this list of 40. The next slide, Mark, please. So some of the research, so these assets, believe it or not, the more assets a student reports or youth report, the less likely they are to get into, like our youth risk behavior survey, identify that they've had risky behaviors, alcohol, tobacco use, inhalants, marijuana, driving and alcohol, sexual behavior, violence, gambling, eating disorders. You can see the whole list. That the increases in the more assets a student has, the less likely they are to consider risky behaviors that in this list. And you can see that those youth that had 0 to 10 assets, right, were more likely, and those that had 31 to 40 were less likely. If we go on to the next slide, some of the insights into the Search Institute's research. Assets and thriving among United States youth. Youth who have high levels of developmental assets are much more likely to engage in thriving behaviors. So you can look at 0 to 10 assets and look at 31 to 40. Succeeding in school, helping others, valuing diversity, maintaining good health, exhibiting leadership, resisting danger, being able to delay gratification, setting goals for themselves, right? And then overcoming adversity. So that resilience, having resilience, the more factors, the more assets I believe I have, the better I feel about myself. I can set goals for myself because I do know I have people in my life that can help me, right? The next slide, Mark. So I kind of rushed through that, but the Search Institute has 2 frameworks, and the first being developmental assets, youth identifying and us helping them identify assets that they have in themselves, and those 40 assets, both internal and external. But they also have another framework, which I love, and I have used this over and over again, and it's developmental relationships, which is related to the assets, because as you develop relationships, you can help develop assets in youth because you have a relationship with them. Before I get into talking about the developmental relationship framework, I want you to think, all of you, about the power of people. And I've done this with many groups and I love this. Name 4 people, and I don't want you to name it out loud, but I want you to think about 4 people who are pivotal in helping you get where you are today. Who are those 4 people? So think it might be a teacher, it might be a family member, community member, a mentor, a work colleague, but who are those 4 people that come to mind that really helped you get where you are today? When I did this exercise, I was surprised. It was my trumpet teacher, and it was and my first principal I ever had in my teaching career. So I was surprised. I hadn't really thought about this, and I think we always assume it's our family, and then sometimes when we really think about it, we realize there were other people that maybe initially we hadn't thought of in that way, that come to mind. Mark, can we look at the next slide, please? So keep in mind those 4 pivotal people in your life. And in SCPHN's developmental relationship framework, when we think about the definition of relationship, I know for myself in education, those top 3 were front of mind for me. I always wanted to express care for my students, challenge growth. I wanted to provide support, both in a social emotional capacity, but also academically, right, in their learning. But I can remember teaching, really thought about what it meant in terms of relationship building to share power with youth and with my students. And especially that last one, expanding possibilities. As a former math teacher in middle school, was I expanding possibilities for students that I was working with? And how was I doing that? In my role as a social worker in a group home for girls, was I feeling that not only was I expressing care and challenging growth and providing support, was I allowing them to share power and feel empowered? Was I thinking about how I could potentially expand possibilities for them and what was in my toolkit at the time? This was 30 years ago. I wish I had had this framework back then. But this framework really comes to mind for me during the pandemic, because those of us that work really closely with youth, when we had to go into a remote environment, were those youth still showing up because we really truly had a relationship with them, or were they not showing up because what we had perceived as a relationship had fallen a little bit short because we were nice and kind? We thought we had a relationship with them, but nice and kind is kind of the beginning start of a relationship to build with kids. That when you're nice and kind with youth, then they're more likely to want to develop a relationship with you. And likewise, right? We want that reciprocity, like Larry had mentioned earlier, that relationships are truly reciprocal in nature. That as a teacher, when I'm asked, do I have a relationship with my students? I would hope that my students would say they have a relationship with me, and thinking about that reciprocity of relationship. When I look at these 5 elements, sorry, Mark, if we could go back a bit. When we look again at these 5 elements and express care, I love that SCPHN has taken it a step further to look at defining it. What does it mean to express care? Being someone I can trust, paying attention when we're together, making me feel known and valued, showing me that you truly enjoy being with me, and praising for my efforts and achievements. I can see myself in doing as an educator or someone who worked with youth, praising for efforts and achievement, really paying attention. And what does it mean when I'm trying to develop trust with kids? Challenging growth, expecting me to live up to my potential, having that mindset that all kids have great potential, pushing me to go further, insisting I take responsibility for my actions, and helping me learn from mistakes and setbacks. Providing support, guide me through hard situations and systems, build my confidence to take charge of my life, stand up for me when I need it, and put limits in place that keep me on track. I like that, Dr. Stephanie Grant, who we're bringing to our spring conference, often references this as being kind of the Mr. Rogers and an Army sergeant at the same time, that you're setting boundaries and so kids know they're safe, and at the same time being that Mr. Rogers for them, so they can build trust in your kind, but knowing that there are limits. Sharing power, taking me seriously and treating me fairly. I don't know how many of you have heard of Hart's Ladder of youth engagement and youth participation, and this really comes into play. Like sometimes we say that we share power with kids or we ask for their voice by doing a survey, but then we never follow back and do a focus group with them. So we're kind of engaging with them, we're asking for their feedback, but we're not putting them on an even playing field with us. We're still then taking control of what we then do with the feedback they give us. In Hart's Ladder, ultimately, the top of that ladder is that both students and adults feel that they have an equal role to play in solving a problem or coming up with a solution to a challenge that they have. And that's really about, and it's not giving up complete control. Sometimes in teachers, we think that that means, oh, good, I'm going to have chaos in my classroom. That's not what that means, but it does go further than saying, would you like to choose a book for your book report? Or would you like to choose this red apple or green apple? It takes it further than that in regards to choice and voice. And then expanding possibilities. I do a lot of work around career pathway exploration and development. And this expand possibilities hits home for me, really close to home in terms of, as an English, math, a youth counselor, a reading teacher, science and social studies, do I see my role as expanding possibilities related to my job? Do I see how I can expand possibilities within, even as an English teacher, and saying, I know there are kids that are super interested in my content. I wonder how I could further encourage that by giving them a book, connecting them to someone. And it's not this huge prep or lesson that I need to create, but it's an intentionality with expanding possibilities for the kids in my room. Next slide, Mark, please. So relationship actions, given the role of strong developmental relationships and creating positive developmental assets, how do you work with building relationships with the individuals you are engaged with and helping? Really reflecting, and back to those 4 pivotal people in your life, which of these developmental relationship elements did they really take care of for you? Like I always think about, you may not have someone in your life that did all of these 5 elements in terms of developmental relationship, but you can think, wow, like my former principal really expanded possibilities for me. And he really shared power with me and challenged my growth. My trumpet teacher expressed care, challenged growth. But I'm not sure if he expanded possibilities for me. But you can see how there are different people that play instrumental roles across these 5 elements, and not one, it doesn't mean that one person has to provide all of it, but thinking about, what small part we can play in the life of a child. Next slide, please. And I've come to a conclusion, and we all have different kind of views on this and perspectives, which I completely appreciate. But fundamental to, I think, everything we do in our lives, whether you're focusing on social emotional learning, whether you're focusing on trauma-informed care or practices, whether you're working on developing a vision or a strategy or doing community work, it's all about relationships, fundamental and foundational to all of that. We look at Maya Angelou. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And this last quote, building relationships is about more than understanding others. It's about making people feel understood. Next slide, Mark. And this really leads in what I feel nicely into what Mark will talk about. And this is kind of this bridge into prevention and the role of community and community relationship. So Mark, do you want to take it away with the video?
I will, and thank you, Carol. I'll turn it up.
Yes, a little, please.
Prevention efforts focusing on the environment aim to build communities that protect adolescents from early substance use. All of the key sectors within a community come together to build coalitions and comprehensive strategies that reduce risk factors for substance misuse and addiction, such as high rates of poverty, social norms, and drug availability, and counterbalances them with protective factors, such as community engagement and healthy activities. Coalitions bring partnerships to communities, and each sector supports prevention efforts. These strategies vary based on the unique needs of a particular community and can include changing social norms around substance use through awareness campaigns, educating people of all ages about the disease of addiction, and teaching adults how to recognize the signs of substance use and intervene if a young person is struggling. Prevention efforts also include policies that decrease drug availability, like imposing taxes on alcohol and tobacco, and passing laws to regulate prescribing practices, and increasing access to evidence-based treatments. Prevention efforts improve the places where young people spend their time, like schools, public parks, libraries, churches, shopping malls, to promote attachment and community engagement, which reduces the likelihood of substance use. Researchers have found that implementing proven prevention policies would save the U.S. billions of dollars annually. More important, prevention saves lives. Community coalitions improve overall community health and increase the likelihood that young people will live lives free of addiction. Together, we can solve this. Join us.
Great.
Well, okay. Thank you, Carolyn. Thank you, Larry. Let me make sure that we've turned that off.
I think, right, one last thing, Mark, we've
You
talked
bet.
a lot about the research on ACES. We've talked a lot about pieces and what Laura, and with Dr. Christina Bethel and what Laura Porter has found that buffers those impacts of ACES. And Mark's going to talk about coalition building, but we know that this work also translates into those 5 elements in the developmental relationship framework, also translates into adult relationships. And we think about the relationships with our colleagues, our relationships with our community. Do we use those 5 elements to think about, do we share power with other community members? Do we expand possibilities for one another as colleagues? And that really parlays into Mark's work. And this idea of intentional positive relationships are the best means for addressing the long-term negative effects of early childhood adversity and for supporting the healthy growth and development of everyone we work with. And we've been increasingly looking at prevention in our work at Pine Tree Institute. And so Mark's going to talk next on how the coordinated response and prevention are working together. Take it away, Mark.
Thank you, Carolyn. And good morning, everyone. And I promise we're going to leave time here for questions. So stop thinking about some of the things that may have triggered some thought or questions in your own minds. And when we get, I guess I get about another 2 hours, maybe 2.5 hours of this heavy stuff, and then we'll get the questions. Anyway, so let me explain a little bit about the work that we're doing in Portsmouth around building capacity through a coalition of sector leaders that have a common interest. And even though we are focusing on substance use disorder and the community response to substance use disorder, this approach, this coalition building and this coordinated response approach can be applied to any social or public health or public safety or any other community related issue, whether it's homelessness or food for those that are less fortunate than us, education, healthcare, and so forth. So we banded together about 3 years ago, a group of sector leaders led by then Senator Martha Fuller Clark, the City Council of Portsmouth, led by Cliff Lazenby, who at the time was the Assistant Mayor of Portsmouth. And they approached Pine Tree Institute with an interest to take a look at how the community could come together to address substance use in Portsmouth and by extension, the greater Seacoast. And so to that end, we brought together a group of individuals from education. I say individuals, they're actually leaders. And let me kind of bring this thing here together. But educators, healthcare, first responders, law enforcement, the Chamber of Workforce Development, housing. We had peer recovery centers like Safe Harbor participate in this, Granite Pathways, and a number of other agencies such as Seacoast Mental Health and so forth. And individually, these quote unquote silos, they had the ability to kind of make a difference in their own swim lanes. And what we found in the model that we put together here is by what's missing is kind of the secret sauce of pulling all of that together in a coordinated fashion. So think of it in terms of a gearbox where you have, the population that we're trying to address, all the sectors that I mentioned, such as education, justice, and so forth. And having them operate in sync, where we're collaborating with each other, we're sharing information, and the outcome that we found was a significant reduction in overlap, and we discovered gaps and barriers to services that perhaps weren't really out in the forefront. So to that end, we collaborated in a series of workshops, and as a result of that, we pulled together a number of different task forces, which I'll talk about in just a moment, that address those barriers, address those gaps in service, and addressed in particular that lack of coordination between those services. So the model involves, and a lot of the things that Carolyn talked about a moment ago in terms of developmental relationships and assets naturally fell into the conversations that we had. So what we wanted to focus on was raising the tide, if you will, of knowledge and education about substance use disorder and the impact that adverse childhood experiences had in downstream behaviors such as substance use disorder. So we put together an outreach and an education program to address that. It was about changing policies, viewing addiction, if you will, as a public health issue as opposed to a criminal or it's not a question of choice. It's a question of dealing with it as an illness. And so changing the way the government of Portsmouth, the municipality, and all the different sector leaders think about substance use disorder, and addressing those barriers, things like access, transportation, housing, finding a job, those issues, knowledge about where the services are and how we have a warm handoff between one service provider and another. So, we don't have people falling through the cracks. And then the coordination of all of these different services to address that lack of knowledge and lack of access and handoffs between different providers. And then most importantly here, we wanted the exercise to be outcomes driven. So we didn't want to get together to just for the sake of having social discussions about, what the problems are. We wanted to be solution oriented right from the get-go. And so as a result of that, I won't name the names here, but you can see who was represented on the steering committee that we put together. And again, city council was involved, the state senator was involved. We had Chief Justice Tina Nadeau, who's been very active in this program. The executive director from Rockingham County's Child Advocacy Center, the County Department of Corrections. We had the chief of police, the chief of the fire department, superintendent and wellness coordinator from the schools. We had Portsmouth Regional Hospital. We had Safe Harbor Recovery Center, Granite Pathways, Haven, and executive director from Haven. We had the Housing Authority represented, president of the Chamber, president of the Economic Development Commission, and Seacoast Mental Health. So as you can see here, it's essentially anybody that had the opportunity to touch individuals that enter into the continuum of care for substance use disorder were invited to the table. And like I said, we had a collaboration where we determined what the top issues were in the community at that time. And keep in mind, this was pre-COVID. So, COVID kind of, set this thing on fire, if you will, in terms of our ability to meet, but also it significantly increased the population of people coming into this continuum of care. And we had to midstream kind of open our eyes and, be a little bit thinking out of the box in terms of how things were manifesting themselves in the community as a result of COVID. I should mention that this model here is not specific to Portsmouth, and it's not specific to substance use disorder. And so, we'll talk a little bit about that as we get towards the end here. All right, let me do this. So I talked about the fact that we had a series of workshops to identify the top priorities in Portsmouth. And this is not to say that these are the only priorities, but given the fact that we had a finite period of time that we wanted to address this, we prioritized on these, and we did pivot on one or two of these things midstream. And I'll talk a little bit about that. I'm going to go through each one of these in a little bit of detail with a focus on the outcomes that we saw. So the priorities that we came up with, number one, access. That originally was transportation pre-COVID. So how do we get people to their appointments? Excuse me. How do we address public transportation as a category to ensure that people can get from point A to point B, ride sharing and things of that sort. However, as I mentioned, COVID hit midstream. This effort started back in late 2018, coming into 2019. And so transportation quickly pivoted to access to services. And by that, we mean access to telerecovery, telehealth services. And so we focused on providing connectivity to those services in the form of a program where we handed out phones. And I'll talk a little bit about that in more detail. The second is recovery housing. When we started this exercise, there were exactly 0 recovery homes in the seacoast of New Hampshire, and I should say Rockingham County. As a result of some of the work that we did, as well as the relationships that we developed, I'm proud to say that as of today, there are 2 recovery homes, both of which are in Hampton, one of which we had a direct impact on, the other which we invited them to join the coalition. So some of you may be familiar with Magnolia House, which is a women's recovery home just outside of downtown by the Old Salt in Hampton. A very successful operation there. The house itself is just a beautiful, warm environment. And when you talk to the operator, Jules Johnson, you'll understand that her core value proposition, this particular to her tenants as well as the community, is restoring self-esteem, making people feel good about themselves. And she's created a very warm environment. And Pine Tree Institute and this coalition is very proud to say that we've been able to help Jules and connect her with a property developer. And within the next 2 weeks, we're expecting to see Summerwood House in Hampton open for men to live in, and it'll be the second recovery home in Hampton, the second one in Rockingham County, and it'll provide up to 12 beds for men that are in need of living in a safe and sober environment. So, we went from 0 beds to something around the lines of 24 to 28 beds over the course of this exercise. Number 3, community education. And this is in the form of providing ACES training. We have a master training program at Pine Tree Institute, and we're embarking on an ambassador program. We showed that way up front of this presentation. And so what we're trying to do here is to raise the tide of understanding and empathy to individuals that have experienced childhood trauma, provide an opportunity to train these people on positive childhood experiences, as well as the developmental assets and developmental relationships model, so that all of the boats within that tide get lifted in terms of a common knowledge of what these people have been dealing with in the relationship to substance use disorder. And this particular exercise is pivoting quickly to an upstream prevention model. The fourth one is employment. And this is in the form of workforce development programs to assist job seekers, as well as the Recovery Friendly Workplace Initiative that creates education and training for companies to not only recruit people that are in recovery, but to retain the people that they currently have on board that might be having a challenge. And it's a great model that we've integrated into this particular work effort. And then last, but certainly not least, the gearbox, coordination of services among these five areas. So quickly, access and connectivity. Let me just do a quick time check here. We're doing okay. So we had a Seacoast Health Connect program that was in partnership with T-Mobile and Seacoast Public Health. And what we did was we acquired smartphones that were preloaded with connectivity, and data plans were paid for through a grant. And we provided these phones at no charge for those that are in recovery. So we handed them out to a number of different partners, including Safe Harbor, but we provided phones to people coming out of corrections. We provided phones for people coming out of treatment. And this program allowed people to have access to telerecovery and telehealth services, connectivity to their parole officers, connectivity to their families, and so forth. So this was a program that we put together under the Portsmouth Coordinated Response. The second one being recovery housing. I talked a lot about that. One thing I didn't mention, before we had Magnolia House and before we even had an opportunity to talk to bring Summerwood House to bear, in the late 2020, I think it was in the third quarter or fourth quarter of 2020, there were over 80 individuals within Rockingham County that needed to be referred outside of the county because we didn't have any recovery housing. So as you can see here, there's a huge demand for this type of a program. Some of the barriers that we uncovered were lack of operators. So we are helping out existing operators regarding some of the financial barriers. We've been able to secure grant money from private donors to offer up to operators in a fund the ability to, acquire furniture, prepay rent, insurance, things of that sort. So there are a number of different barriers in the greater Portsmouth area, but if we widen, the focus to the broader Seacoast, we were able to make this work. And as a result, we had a direct impact on one new home, and we are providing support and integrating operators that are currently out there to have visibility to this program we're having in Portsmouth. So more here as time goes on. We expect to continue to work with new operators in the Seacoast and hopefully bring additional housing to bear. Task force number 3 was the community education, which I talked to, providing training and education on ACEs and PIECES and related trauma-informed care as it relates to substance use disorder. And we've got a significant database of organizations that offer services, direct services or indirect services to youth and young adults, and they are our targets for that training.
Mark, I think someone was chiming in.
Hi, Mark. It's Ashley. Thank you.
Hey, Ashley. How we doing?
So the next session starts in 3 minutes. So I just wanted to give you a time check. The session workshops 1 were ending at 10:30.
Oh, my bad. Oh, well.
Give a quick summary and give people the chance to take a deep
Sure.
breath before they jump into their second sessions. Sorry.
Got it. I'm going to wrap up by saying what we've learned is, this is a community problem. Coordination, as I mentioned earlier, is the secret sauce. We're moving upstream as it relates to prevention. And then where we're going here, we broadened Portsmouth Coordinated Response to a broader Seacoast. We're doing this in Kennebunk. We're expecting to do it in Sanford. And we continue to move upstream as we offer prevention services. So the challenge I'd leave you with, what actions can you take to move upstream in the continuum of prevention, treatment, recovery, and reentry? And think of a couple of people over the next 2 weeks who you can call and discuss how to implement these actions. So let's get the word out that this is available. So with that, Ashley, I'm going to stop. And I guess we have time for a couple of questions.